You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 11th, 2025. Our topic is Hereditary Angioedema, presented by Dr. Timothy Craig. He's a professor of pediatrics at Penn State University, is on the Medical Advisory Board for HAE, and is the Director of Allergy and Immunology and Respiratory Clinical Research.
Everybody, this is Conferences Online in Allergy. I'm Chris Miller, the Director of COLA, and today our next presentation will be Dr. Timothy Craig. He is a professor of pediatrics at Penn State University and one of the experts in hereditary angioedema, and quite a lot of work on the alpha-1 antitrypsin also. So with that, Dr. Craig, I'll hand over the controls to you, and thank you for being here.
Hey, no, thank you. I've done this a few times in the past, and I'm very appreciative, especially that you make it so everybody can look at the presentations at a later date. You know, our fellows have dug up some of your other presentations that you post, and we're really appreciative, so thanks. Can you see my pointer?
Yes.
You can. Okay, good. So this is our medical center. It's the middle of nowhere. We have more cows than people, but we have covered a huge area. And right there is my home, if you're looking for me. I've been here now for 30 years, and in that I've kind of focused on HAE, which has really occupied a big part of my career. And it's been a very exciting disease state in what's happening. So what I wanted to do today, if I can see if I can forward my, can I forward it? For some reason I can't see that bar. Okay, cool. So I do have some conflicts. I think it's really every company that makes a drug here. I would feel really embarrassed if anybody felt I was being leaned to one company or another. So please, if you feel I am biased at all, let me know so that doesn't happen again. So what my objectives are, I just wanted for the first year fellows go over what the pathway is and what the pathophysiology is for hereditary angioedema. And then I wanted to kind of go over the impact on people, wanted to go over how to differentiate it from histamine-induced disease, and then look at those therapeutic options we have now available. But I also wanted to spend some time talking about the future therapies, because unlike many small disease states or orphan disease states, this has had a lot of attention and has unbelievable research going on in the field. I think that's exciting for me, but I think now it's going to be calming down a little bit. But, you know, if any of you really want to build a career, I think alpha-1 antitrypsin deficiency is one of those places that is just about starting where HAE was 10 years or more than 10 years ago, back in 2009. So, yeah, if you're looking for a career to build in a rare disease, I think that's the space to look at now. You know, from here you can tell what effect it has on people. You know, this is the cosmetic aspects, right? But really what everybody worries about is their attack they'll have of the upper airway, which could kill them. So the three areas that it attacks the GI tract, causing belly pain, nausea, vomiting. It attacks any skin surface, and that's what you see here. And then it attacks the upper airway. Now, there is some discussion by other allergists, and we just looked at CKs from muscle, and there is some evidence that maybe other organs are involved, but these are the three big ones. So, you know, prior to 2008, there were no drugs in this country. That was when the first drug was approved. Before that, we used androgens, which for women especially wasn't very exciting, obviously. And then we had fresh frozen plasma. So really, up until about the mid-teens, 2015, well, it's really a little later, 2017, when we got the drugs that are out there right now, we really kind of used rescue therapy more so than anything else to make this woman into that. Now, grant you, this is a lot of cosmetic change, background change, just like plastic surgeons do. But nonetheless, I think when you look at her, you can see how good rescue medications work. But then also, you had to worry about having all your attacks, right? And so it was really complicated, and you would have to go to the emergency room, right, to get the FFP. You couldn't have that at home. But now, you know, almost all the therapies except for one or two can be self-injected. And now we're really mainly have people on long-term prophylaxis so that this young lady can really be with her friends, not worrying about having an attack. She still needs to carry a rescue, just like a bee sting person, a food allergic patient needs to remember to carry their EpiPen. But in more cases than that, they can travel in an airplane, go on vacation, and do everything that you and I can do. And that's really amazing that in that period of time, from 2008 to now, we've had this big contrast in quality of life issues and so on. So let's kind of look at what HAE is about. So first of all, you have to always differentiate mast cell and those that are bradykinin induced. And we'll go over the bradykinin induced ones in 1 second. But the main thing between the two is mast cell tends to be red, tends to be itchy. Often urticaria occurs with the angioedema. But remember, a good portion of people who have histamine-induced disease have only angioedema and never hives. These symptoms tend to be rapid in onset and rapid to resolve. It affects mainly the skin and the oral pharyngeal area, rarely affects the GI tract. Maybe in profound anaphylaxis it does, but that's not what we're talking about here. This is angioedema. It also is not familiar, even though allergies are familiar. Angioedema is not, or at least we don't know of it being familiar, except in some rare cases. It does often respond to antihistamines, but please remember, not always. So remember the guidelines, just like for urticaria, is 1 antihistamine. If the angioedema doesn't get better, you go to 2 twice a day of a second generation. And if that doesn't work, you go to 300 milligrams of omalizumab. You could do dupilumab now too as well, but I think omalizumab is cheaper. And then if you don't respond to omalizumab at 300 a month, you can go up to 600 every 2 weeks. And you'd say, well, that's very expensive. But remember, that's a heck of a lot cheaper than any HAE drug. The HAE drugs are about $500,000. Omalizumab at 600 every 2 weeks is about maybe $100,000. So big difference between the two. In addition, mast cell disease, angioedema is usually not life-threatening. It can be, but that's usually when people have anaphylaxis, not just angioedema. In turn, bradykinin is a lot different. It doesn't occur with urticaria, except for a very, very, very rare exception, which I'll talk about in a second. It is possible to have HAE, right, and just by chance also have hives, since it occurs. So hives occur in about 20-25% of people sometime during their life, but it's usually not a big part of it if they do coincide and they're not really related. The vascular permeability is what causes the symptoms. The swelling tends to be slow in onset, lasting for days, slow to resolve. Now, in reality, sometimes the attacks are much shorter than days, but for fellows, you know, that it's 2 to 5 days of swelling, even though sometimes it does turn around within a day. Fortunately so, the thing we dread, the upper airway attacks, only are affected about 1% of cases. Some studies show that it's more common, like phase 3 studies, but that's because people with a hand swell might not go to get treated. If they have a throat swell, they are. So I really think it's more 1% than 3%. This does have a rash with it, erythema marginatum, which can be mixed up with urticaria, so you have to be very, very careful at that. This is a serpiginous type rash. I think I have a picture next slide or two, and it doesn't itch, and it doesn't have a wheal, but if you're not aware of how to make a diagnosis of urticaria, you may get confused by this. Here, family history is usual, not always, and we'll talk about that in a little bit. And this does not respond to antihistamine. Instead, it responds to those medications we'll talk about in a little bit. Probably the biggest hint, though, is not having urticaria and having frequent abdominal pain. So the skin swelling and abdominal pain is almost 50-50 split. So if you see someone who has a belly pain 1 week and then 2 weeks later has a skin swell and they don't have hives, start thinking about hereditary angioedema. So these are all the these are all the bradykinin-induced disease. So we have type 1 and type 2, HAE. We have type 3, which now you have to call normal C1 inhibitor or hereditary angioedema with normal C1 inhibitor. That's 12 syllables, so I'm not going to call it that. I am going to call it normal C1 instead. And then we have ACE inhibitor-induced, and then we have acquired-induced. So how do we distinguish these? Well, I think some of them are easy, like the history of ACE inhibitor, but let's walk from left to right here. So type 1 hereditary angioedema, what happens is the protein misfolds, doesn't get secreted. So here, the protein is low. With that, the function's low, and C4 gets consumed because remember, C1 inhibitor prevents C1 from activating C4. So if you don't have C1 inhibitor here, C4 gets consumed. Rarely do you need genetic testing for this. If you are going to use it, it's probably for in utero, if you want to have a fetus diagnosed, or the first year of life, which sometimes the biochemical testing is confusing. So how about type 2? So here, it's a little different, right? They look the same in presentation. Type 2 is what happens is the protein folds correctly to get secreted, but the enzymatic head is defective. So here, the protein will be normal or elevated, function will be low, and C4 will still be consumed. This is important because these are the ones that in low and medium income countries are missed. Fortunately so, it's only 15% as compared to type 1, which is 85%. But here, sometimes you might need genetic testing if that's available, say in a low income country, and you don't have the functional assay. And functional assays are very difficult. It has to stay frozen and so on, which kind of makes it difficult to do in low income countries. So in most cases where you are and where I am, you don't need genetic testing either. But if you're in a mission, medical mission somewhere in the world, you may want to save that for genetic testing so you don't miss this group of people. So how about normal C1 inhibitor? Well, by name, right, you would expect them all to be normal, which they are. It is essential that you get genetic testing on these people. And the reason for that is the therapy that is to be used for these people varies by the genetic abnormality they have. And I'll talk about that in 1 second. And then we have ACE inhibitor induced, right? It's supposed to be bradykinin. For fellows exams, it is bradykinin. I can tell you, I think there are a fair amount of these are histamine induced or maybe mixed. And, there are some literature that people often who have ACE inhibitor, some of those individuals later on, months later, go on to develop hives, which makes me think that maybe, but for board purposes, recertification, ACE inhibitor is bradykinin induced. Here, though, it's a decreased catabolism, right? It's not an increased production. In HAE 1, 2, and 3, it's increased production. And in acquired, it's also increased production. But in ACE inhibitor induced, it's decreased catabolism. But that's why you never want to give this to any of these others, ACE inhibitors, right? Because if you have overproduction and then you have decreased catabolism, you could see why that would be a problem. And then lastly, we have acquired angioedema with low C1 inhibitor. So this has low protein because it gets destroyed, but usually an autoantibody. The function's low for that reason. C4 gets consumed. And about 75% of people have a low C1Q, not 100%. I think for board purposes, you would say, yes, it has a low C1Q, but in reality, you may miss them. So if you have a late onset angioedema, that looks like hereditary, but the person has their first attack at 45, you'll probably get a C1Q, right? And if that's normal, you're probably best to get genetic testing to exclude that they have a type 1-2 HAE, because acquireds do occur later in life, usually in the 40s or 50s or later, and almost all are like marginal cell lymphomas or monoclonal gammopathies. But if you have the C1Q, that's reassuring, and if you don't, consider maybe doing genetic tests to prove that they don't have hereditary angioedema type 1 or 2. So here we are. This is the awful part of what's going on now. So remember I said HAE are people, they have bradykinin and you don't have hives, and I said there's an unusual group of people that do, not by chance alone, but because of the genetic abnormality they have. So this is the different, 8 different, 1, 2, 3, 4, 5, 6, 7, 8 different genetic abnormalities that have been found. You have coagulation factor 12, and I'll show you where that occurs in a future slide. Is really up front on the pathway. You have plasminogen, which is also controlled by C1 inhibitor, that pathway, the fibrinolytic pathway. We have angiopoietin 1, and we're not sure exactly what the defect is for that one. We have cholinergen, which we think we know what the defect is of where the protein, I'm sorry, let me back up. We know what the genetic defect is, and we know what the protein is, but we don't know exactly how it causes the angioedema. So coagulation factor 12, we know. Plasminogen, we think we know. Angiopoietin, we're not too sure. Cholinergen, we think we know. Myelofurrin, maybe direct permeability. Heparin, we're not 100% sure, but it probably is the negative charge activating factor 12, gain of function. And then we have these 2 others that more recently mentioned, carboxypeptidase and then the VEGF. These 2 may be permeability, they may not, we're not sure. These people do get hives as well, though, and that's the confusing part. Now, there's only been a few cases of both of these, so probably you could still go by having, if you have hives, you're probably more likely to have histamine-induced disease, right? So just keep in mind that these 2 do occur with hives. I don't think any of these, except for maybe the coagulation factor 12 and plasminogen, would be on a board because these are much more rare, if you want to use that. More rare, or rarer, I guess would be a better term. So what about the pathway? So this is the pathway. So factor 12A sits there. It has a variety of factors, right? It inhibits the activation of factor 12, of C4, right? Sits and inhibits the activation of C1QRS so that C4 is preserved. It also inhibits the coagulation, the plasminogen and fibrinolytic pathway. It sits on top of the coagulation pathway, which I don't have here. And then it sits on top of what we call the contact or the bradykinin pathway or the kallikrein pathway. I prefer to call it the contact. So what happens is factor 12 is activated all the time, and C1 inhibitor shuts that activation down, except for if there's a reason that you need that to activate the pathway, such as in an infection. So negative charges can activate factor 12A. And then, like I said, if you don't have C1 inhibitor, pre-kallikrein is activated to kallikrein. Kallikrein activates, goes back and reactivates factor 12A, increasing that activation process. So you get like a cascade that's amplified. And then factor 12A itself, when it's activated, also can cause that cascade to increase. So you get this kind of double amplification of the pathway. Once kallikrein is active, high molecular weight of cholinergen gets fragmented, becomes bradykinin. Bradykinin goes, binds to the endothelial cells, and causes the swelling that we see in these people. And if you look at what happens, here's the endothelial cell. You have a B2, bradykinin B2 receptor. When bradykinin binds to it, it activates cyclic GMP, prostacycline, and nitric oxide. And that causes the changes we see in these people. And this is just to show you what happens and how the angioedema occurs. So these are endothelial cells in all 4 pictures, right? Here you can see between endothelial cells with the pink nucleus, you have this tight junction in green. Here you have the nuclei in blue, and you can see you don't have many actin microtubules inside that cell. And then you put bradykinin on, and you can see these tight junctions that's dissolving, and you can see all these microtubules forming inside the cell, pulling that cell inward away from its buddies, the endothelial cells around it. So you can see why the fluid would shift from the intravascular space into the interstitial space because of these reasons. So what about, I want to just talk about type 3 or normal C1 inhibitor just a little bit, because it's, like I said, probably not going to be on your boards. And these are all very, very rare. There's been two articles recently published, though, about this. One looking at international and one looking at national. I think when you read those papers, one was by Mark Rydell and one was by Bruce Zurl, you have to be very, very careful of interpreting those data, because the cohorts of people, some of them didn't receive anything more than one antihistamine. Now, some of them never received any omalizumab. Some of them were never genetic tested. So how could they call these people normal C1 inhibitors? I don't know. And so when you read them, you have to be careful. But these are the genetic abnormalities we know. And again, the reason why you need to, any type 3, you need to get genetic testing on. So factor 12 gain of function occurs right here, right at the top. So any of those drugs I talk about, which inhibits prekallikrein or kallikrein or inhibits bradykinin, would work for these individuals, right? Plasminogen defects, which is down here, we thought worked by factor 12, but CSL just got a new drug approved, and when they looked at the plasminogen abnormalities, their drug that inhibits factor 12 did not work. So now we know that plasminogen activates kilinogen directly. So again, the importance of genetic testing, because you can predict which drug would work. The drug that would work are ones that inhibit bradykinin receptor, right? If we look at VEGF, and the carboxypeptidase, there are some cases have seemed to say that icatibant may work. And so that would direct you, if you had these two defects, to maybe use an icatibant for treatment. There is the kilinogen abnormality. That's where kilinogen is auto-activated, generating bradykinin. So again, you know that those drugs up here aren't going to work, right? You have to be down here at the bradykinin receptor. And then we have these two, angiopoietin and myelferrin, which may be direct permeability, and maybe none of these drugs would work. And in that case, I don't know what you would try. Maybe tranexamic acid. I don't know. But so this is the only slide I'm really going to have with the genetic abnormalities. But I do want to stress the need to get genetic testing so you can determine where in the pathway and which drug you would use for that particular person. So let's talk about treatment of HAE. So this is the kind of the foundation. Every person with HAE needs to have on-demand therapy. And I would say they all have to have 2 doses, right? And because none of these medications are 100%, icatibant 10% fail to respond to the first injection. Sebetralstat, which was just approved a couple of weeks ago, 20% of people don't respond and need a second pill. And even C1 inhibitor IV, not 100% of people respond to, but close to it. They need to treat themselves early. That is, you don't want to sit and wait. If you wait more than 6 hours, these drugs aren't going to do much benefit. And so that's one of the nice things. There are a lot of people who are needle phobic, and I feel that the pills, as they come out for both prophylaxis as well as rescue, are going to have an advantage for people to use them earlier on and not have to get someplace to inject themselves. But the earlier the treatment, the better. The less morbidity, the less mortality. The treatment of attack should be irrespective of the site of swelling. Now, if it's a weekend and you only have a slight hand attack, you need to use a $10,000 medication injection. Maybe not. But, one of the things that used to be a problem is that people didn't make it to work because they had a foot swell, or they got to work and they couldn't work because they couldn't keyboard. So for that reason, we say that all attacks should be used. And then everybody needs to have a short-term prophylaxis. And when they say short-term prophylaxis, so they're going to have an endoscope placed that goes past their vocal cords. So if they're going to be intubated, if they're going to have a traumatic surgery, and not traumatic in the sense of having trauma needing surgery, but if they have, a surgical site that is opened and causing a lot of disarray of tissues, if they're going to have an extraction of a tooth, all those reasons they need to have short-term prophylaxis beforehand. So you have to have a plan, not necessarily the medication, but at least a plan. So this is what we have available. So ecallantide is a drug that inhibits kallikrein. It's approved for 12 years and older. It does have a risk of anaphylaxis in about 3% of people. For that reason, it can't be self-injected. So what happens here, you have the patient calls up a nurse and the nurse goes to their house. And that sounds really strange in this day and age when all the other drugs are self-injected. But I can tell you, I've had some situations where I need to do this. I've had some inner city kids whose parents were rarely at home and they were out getting drunk or using drugs, and the 12-year-old would be at home and have an attack, and no 12-year-old kid is going to be allowed to walk himself into an emergency room. But they could call the nurse who would come and give them the medication. So though I only have a few people on that, it is a drug that I have used, and I think it has a place. Icatibant is approved in the United States 18 years of age. Its only really adverse effect is about 97% have an injection site reaction, and some significant. It is self-injected. There are now about 5 different generics, so it's now gone down. It used to be 12, 15,000 injection. Now it's down to about 6. So I think, that is the drug of choice now. It's self-injected, it's sub-Q. Really, other than the injection site reaction, it has no other real safety issues. There's also C1 inhibitor, both plasma-derived and recombinant. They're both available for children from age 6 and up. Actually, you can use it at any age child, really, the plasma-derived. Recombinant is approved for adults and adolescents. They really have no adverse effects. Potentially anaphylaxis, but it's so rare, I've never seen it, and I've used thousands of doses. There is, though, the recombinant is made in rabbits, and initially there was some residual rabbit antigen. Now it's pretty pure, but nonetheless, if you have a rabbit allergy, you probably shouldn't use recombinant. I have to say, though, here, if we go back to icatibant, this is the drug of choice for rescue for me. It is approved down to age 2 in Europe. We have it in our hospital down to age 2. You have to dose adjust it, though, and that formula is in the package insert. So we, in our ER and clinics, we give it down to age 2 off-label because it's only approved to 18. But to get an IV in children is really difficult. To get a sub-Q, it's difficult, but a lot easier to try and get in the vein. So that's what we use now for treatment of attacks. So where do these medications sit? So the plasma-derived and the recombinant-derived sit up here. We place in C1 inhibitor that's deficit or defective, and that's how it works. Ecallantide shuts down kallikrein, and then the icatibant works by inhibiting the receptor bradykinin in the competitive inhibition system. So those are the drugs we have available. So what about short-term prophylaxis? Well, this is what you don't want. A person who has a normal getting, say, a upper GI and they don't get prophy and it irritates the vocal cords, and then they have an attack. And then they end up being intubated and resuscitated. So that's why you need short-term prophylaxis. So, I'm sorry. So what drugs are available for short-term prophylaxis? So you can use either recombinant C1 inhibitor or plasma-derived. I'll talk about the dose on plasma-derived in a little bit. If you have nothing else, like you're in South Africa, FFP might be the drug of choice. You can use androgens, but remember you're inducing a protein. So you have to start it about 5 days before the procedure and continue it a couple days after, because your risk of having a reaction extends out to about 72 hours after a surgical procedure. So those are the drugs here, and androgens work by increasing C1 inhibitor production. That's a controversy, but I just had a friend of mine just prove that in a cell system a week or two ago. You can use tranexamic acid, and for most of the people who have type 3 disease or normal C1 inhibitor disease, that's the drug of choice, unless you genetic tested them and found them to have one of those genetic abnormalities. But those who do not have genetic abnormalities, tranexamic acid seems to be just as good as any of the other drugs out there, according to a recent publication. And what else? Those are it. So let's look at what the guidelines say. Well, the guidelines say the drug of choice is plasma-derived C1 inhibitor. They don't talk about dose, but I'll go over dose next. So this is a study done by Bork. I call him the granddaddy of HAE. He is older than me, so I guess I can do that. But he also has more patients than anybody else in the world. So this is a study he did with oral extractions, tooth extractions, right? So some got no prophy, some got 500 units, some got 1,000. So if you look at those that got no prophy, it's about 22% of people had swelling related to their HAE. If you gave them prophy with 500 units, you decreased that to 17, but not to none. If you gave them 1,000 units, you decreased it down to about 7.5%, but none. Not none. So what I dose is I dose 20 international units per kilogram. This is extrapolated by C1 inhibitor given for acute attacks. We know that you got to that point where you inhibited the pathways. So there is no real good data looking at it for prophylaxis, but I use 20 international units, which for the majority of us listen to this, including myself, we'd be getting about 1,500 units, right? Because 80 kilograms is what the average American is, so it'd be about 1,500, hopefully decreasing that risk even more. Plus, it allows me to treat a 200 kilogram male different than, say, a 10 kilogram baby, right? What you never want to do is waste this, though. So if you do 20 units a kilogram, of, say, a kid, and it comes out to be 250 units, well, you're not going to pour that down the drain. You're going to give them the 500 units because each vial has 500 units. So you're going to round it up to the nearest, round it up or down to the nearest 500 because it's worth its weight in gold. So how about long-term prophylaxis? What do we do for long-term prophylaxis? Well, you know, we used to look at attacks and say, well, if you have more than an attack a month and you have more than 3 days of disability a month, that should be ample to get treated. If you look at some places like Australia, you have to have 8 attacks per month to get treated with long-term prophylaxis. I think in the United States, fortunately, you know, we don't have much constraints on medical costs, but I think what people do in the United States look at a couple of things. You look at overall burden of disease, how many attacks, how many attack days. You look at its severity, how is it compromising a person's life, how is it compromising their overall psyche, is there, do they have frequent urgent care visits, do they have anxiety that's disabling, do they have absenteeism from work or being fired from work or not getting into school. So we use all these kind of gray areas or soft areas, and we use that to decide by shared decision making whether or not someone should have long-term prophylaxis. So what do the guidelines say? Well, they say you use long-term prophylaxis to normalize patients' lives. They don't give you any idea exactly how to determine that, but they say to, you know, take into account of the disease severity, the burden, and they don't give you anything concrete. So again, from the other slide I just did, I think you have to look at all those gray areas. They also say that sometimes it's more of a time instead of a procedure, right? So if you're going to get married and go on a honeymoon, maybe that's a good time to go on short-term prophylaxis, right? So you're not worried about yourself. If you're going to climb a mountain, you know, Mount Kilimanjaro, you probably have a good idea that maybe you should take short-term prophylaxis for that time, even if you don't have an indication for, say, long-term prophylaxis. So, you know, when they talk about, you know, complete disease control, and sometimes that might be just short-term prophylaxis. At other times, it may be long-term. But again, when we're talking about long-term, you look at all those variables we just talked about. And what are the medications we have available for long-term prophylaxis? Well, you have plasma-derived C1 inhibitor. It's safe. It's approved for 6 years of age and greater. It varies by your weight and by your age and by the drug you use. The only problem with it, it's pretty burdensome, right? It's an IV injection every 3 to 4 days. So I'd say that's the adverse effects are minimal. It's the burden that's a problem. You could do sub-Q plasma-derived, easier than IV, right? It's approved for 6 years in age and older. It still is a injection twice a week. So still a pretty good burden. Safety-wise, it's very safe. We have lanadelumab, sub-Q, just like plasma-derived sub-Q. They're about equal in efficacy, and I'll show you that in 1 second. But lanadelumab, I think, is preferred for a couple of reasons. One, it's age greater than 2, so it's down to a lower age, and it's also injected every 2 weeks to once a month. It does have some adverse effects. It does have about a 47% injection site reaction. It does have some other adverse effects, but they're minimal. And thus, the advantage here of lanadelumab is that it's infrequent dosing as compared to those plasma-derived sub-Q and IV. There is berotrostat now, which is the oral medication. It's approved down to age 12. It's 150 milligrams with food. There is a lower dose if you have kidney function abnormalities. It does cause some problems. You do have abdominal pain, nausea, sometimes diarrhea and vomiting in the first 2 weeks, so you have to tell the patient that. The other thing is berotrostat takes about a month or more to work, right? And that's the same with lanadelumab. So with both berotrostat and lanadelumab, you have to warn your patient that they may not have complete control right off the bat, because it might take a while to have the effect greater enough than to suppress the attacks. We also have danazol. Oh, and it is just a tablet a day, which makes it a good start drug, I think. When we talk about efficacy, you can see it's down to about 47% or about 50%. So it's probably a drug that a lot of people, you'll start and fall off, but there are some very good responders. We also have danazol. Don't want to use it in kids, right? Don't want to use it in pregnant people. Probably you don't want to use it in women. And you probably don't want to use it in men anymore either, because the adverse effects. It does work, and it works extremely well, even though the literature out there says not. It's people who don't have any experience using danazol. It works very, very good. But the problem is you have elevated LFTs, so you have to check LFTs. You get elevated hematocrit, so you have to check the CBC. You get hyperlipidemia, so you need lipid panels. Causes hematuria, so you need a UA. And it is an increased risk of hepatocellular carcinoma, so you have to get ultrasounds. So it's the adverse effect profile that really inhibits its use. And then we have tranexamic acid. It does need an eye exam. It probably is maybe increases slightly thromboembolic phenomena, but I think for most people who have not genetic identified normal C1 inhibitor, the rest probably that would be the drug of choice according to the new article written recently by Bruce Searle. So where do these drugs all have effect for long-term prophylaxis? Well, plasma-derived is replacing the C1 inhibitor. It can be used IV or sub-Q. Sub-Q preferred because it's easier access if you're going to use that. Again, it has frequent injections though. We have lanadelumab, and berotrostat inhibits kallikrein. And we have tranexamic acid, which inhibits the fibrinolytic pathway. And then we have androgens that work by increasing C1 inhibitor. So that's what we have available right now. And we'll talk about what's coming in the future, which is an amazing thing. So let's kind of look at how good these drugs are. So this is C1 inhibitor, 1,000 units every 3 to 4 days. That's how it was initially approved. It gave you a 50% reduction of attacks. So this is birds on a wire, right? Here's placebo people. Each one of these tabs, if you want to call it that, is the severity of an attack, whether or not they used rescue, how long it lasted. And you can see the density between placebo and actively treated is remarkable, but it's only about a 50% reduction of attacks. Now remember, you can go up to 1,500 or 2,000, and that should be international units, not milligram. I apologize, I didn't pick that up. But remember, then you increase the cost. So at 2,000, international units, I'm sorry, let me back up. If you're given 2,000 units every 3 to 4 days, you're talking about $1 million over the course of a year. So, I think using it 1,000, it's about 500,000. But really the efficacy you get for that is minimal. So I would say that you probably don't want to stay with IV C1 inhibitor because of that. You can go to sub-Q, and here you have easier dosing, right? It works really well. It works about 85% effective at suppressing attacks. If you look at birds on a wire again, here's the placebo. Here's those actively treated. This is the dose that we use in the United States, 60 international units per kilogram. Here it's 86% reduction of attacks. So you get much better efficacy, and it's even cheaper than the IV 1,000 units injected every 3 to 4 days. And again, less. It's frequent injections, just as many, but it's sub-Q instead of IV. Well, what about lanadelumab? Well, here again, you get placebo. Here's lanadelumab, 300 milligrams every 2 weeks. You can see an 87% reduction. So this and sub-Q C1 inhibitor are about comparable in efficacy, except for here you have the benefit of every 2 weeks instead of twice a week. And then you can go out to 150 a month after 6 months of good control. But you can see you do lose some efficacy. You go down, I'm not sure of the exact number, maybe 75% or 72% reduction of attacks. But probably worth trying that. I still have a hard time with people. It's hard for me to say, hey, let's go down to once a month. See what happens if you have attacks. And if you do, we can bring you back up to 2 weeks. I just think people just have such great change in quality of life by not having attacks. It's hard to convince them and myself to try that, but sometimes the insurance kind of obliges us to do it. Then we have berotralstat, which is the tablet, right? Here, there's no birds on a wire. So here you can see about 3.2 attacks per month. Goes down to about 1.6 attacks per month. So it is about 50% reduction of attacks, right? So, but what happens if you have people on it? Those who are not doing well drop off, and then you're left with a cohort of people that are good responders that tend to have, 80% reduction of attacks. But the majority of people are not going to have that benefit. You have to remember the adverse effects. They wane after a couple of weeks, but make sure you advise the patient of that. And then you have to, like lanadelumab, you have to tell them berotralstat also has a delayed effect. And let me go back to lanadelumab if you can see that. So yeah, you can. So you can see that the first period is when you tend to still have attacks, and then you do better later on. And the same with berotralstat, you can see slowly you get down to your level of attack reduction. So what about new therapies? Why do we need new therapies? Well, my thing, this is someone else did this slide, but when I look at it, well, I think the efficacy we have now is pretty damn good, 85% or greater. So I don't think that's a reason. Increased safety, well, the drugs that I talked about are all safe except for maybe calitide with that 3% of anaphylaxis. Reduction of treatment burden, I think, is it. That's the real reason. There's other things too. Reduction of treatment burden, including oral therapies, maybe some gene therapies. But the other thing is hopefully accessibility, right? The vast, vast majority of the world will never see these drugs or have never seen these drugs. And hopefully more drugs coming in will allow drug prices to go down so that people in low and medium income countries will have exposure to these drugs in the future. So what are they? So this is what we have right now. Sebetralstat, 3 weeks ago was approved. This is an oral medication for rescue. And I'll show you the data on that. Calvista did look at this drug also for prophylaxis, but there was some liver toxicity, but that's not been seen in the studies done for rescue. It's comes in a 4-pill box. They take 2 pills for treatment, and then the other pills are there in case you need to be retreated. Again, it tends to be have minimal adverse effect, and it's approved for adolescents and adults, and they're doing a pediatric study now. We have garadacimab, which was approved a few weeks ago. It's a CSL's drug. It is for prophylaxis, unlike sebetralstat, which is for rescue. This works by inhibiting factor 12. It has a very minimal side effect. They give a loading dose, so it has effect right away. It is factor 12 inhibition, but they did studies to make sure there was no bleeding or clotting, and there wasn't. It is available for 12 years of age and older, and they're doing their pediatric studies right now. There's donidalorsen, which is an RNA technology and inhibits the production of prekallikrein in the liver. It is sub-Q, just like garadacimab. Its data probably will come out in the next few weeks, get approval in the next few months. It's probably going to be an injection once a month. They do have data, but the data for every other month, you drop a lot of efficacy, and I'll talk about that in a second. Adverse effects, there was one case of anaphylaxis. Unfortunately, it shouldn't have occurred because the person had a large injection site reaction, came back for the next dose, had a larger one, came back for the third one, had a larger one. They probably should have been stopped right there, and they had hives around that site. So it seems to be a lack of due diligence, but there was one anaphylaxis. There's a new drug, ADX by ADARX. This is, in short, interferon RNA and inhibits prekallikrein in the liver. It looks like you can give it as infrequent as every 3 months. They don't have good data available yet. There's navenibart. This is a monoclonal antibody. It's IgG1. They modify the Fc region with some amino acids, so it binds to the fetal Fc receptor. Let me back up. They take IgG1, modify the Fc fragment, by a few amino acids, so it binds to the fetal receptor. And what happens, unlike if it bound to a regular receptor, where it's brought into the cell and destroyed, the monoclonal, here, if it binds to the fetal receptor, it's brought into the cell but spit out and not destroyed, so it tends to keep on recirculating. And it inhibits kallikrein. And I'll show you where that works. Seems to be once every 6 months. They have data on 3 months now, sub-Q. That looks great. I'm waiting to really see the 6 month, but if they anticipate it's going to be effective at that. We have deucrictibant. This is a drug by Pharvaris. This is binds to the beta-2 receptor. They're in the studies right now, both for prophylaxis as well as for rescue. It binds just like icatibant to the B2 bradykinin receptor. The rapid one for rescue is a quick release. The other one is a slow release for long-term prophylaxis. So maybe you'll take a tablet a day for prophylaxis and a tablet when you have an attack. Then we have Biomarin. This is a traditional adenovirus. Problem with that was that you got inflammation of the liver, right? Because the adenovirus showed itself in the liver, and those cells were destroyed. And I think that's why it didn't work, because they could not get enough production of C1 inhibitor in order to shut down the pathway. So that's been stopped. But we do have an Intellia, which has some good data now. This is based on CRISPR technology, right? CRISPR technology, meaning you go in, you go out and take out the prekallikrein from the genetic material in the liver, and so they can't produce prekallikrein, and thus they can't induce bradykinin. So that's really exciting. I'll show you the data on that. And then there's a couple other companies that are just starting up and don't have any data yet. So where do these drugs work? Well, garadacimab, which was approved a few weeks ago, that CSL drug, inhibits factor 12 activation. So you don't get activated factor 12 and you shut down the whole pathway. Right, so that would work well, and those people have normal C1 inhibitor with factor 12 gain of function as well, right? We have inhibiting of bradykinin. We have donidalorsen by RNA technology. We have silencing RNA technology in ADX324. And then we have CRISPR technology in Intellia that remove prekallikrein. We have sebetralstat and navenibart that inhibit kallikrein. And then we have deucrictibant that inhibits the bradykinin receptor. So what about how do these drugs work? So let's look how good they are. So this is garadacimab. This is the factor 12 gain of function inhibitor. Here's placebo. Here's after treatment. Here's their their what do you call it, run-in attacks. You can see that the nice thing about this is that loading dose, you get rapid effect right off the bat. I don't like this birds over wire. It stratifies most severe to less severe. I would rather have it scattered about. So you just look at the density, but I don't know, they did it this way instead. But you can see from this that there's about an 87% reduction of attacks. This is looking at donidalorsen. This is the RNA technology, right, inhibiting the production of prekallikrein. You can see here, this is the placebo, here's the active treatment. You can see it takes a while to work because you're inhibiting a protein, so you have to tell the patient about that. It has about an 81% in their phase 3. And if you go to every 2 months or 8 weeks, you drop down to 55%. So I don't know if they'll get come out. They'll probably, like lanadelumab, you'll start with once a month and are doing really well. You might want to try to go down to every other month. I think that's probably what their strategy would be. This is navenibart. This is the fetal, right, FC change. So it has a half-life of 100 days instead of a half-life of like a normal monoclonal of 20 days. It inhibits the kallikrein. You can see here's the run-in attacks, and here's after treatment. So it had about a 90% reduction of attacks, and that's at 3 months. We'll see what happens with their 6-month data. They also give the loading dose, and you can see the effect was rapid. Then we have Intellia. This is data from New Zealand, which was their kind of phase 1, you could call it, or phase 1-2B. So they had people come in, they 3 doses here. They had people come in who were on prophylaxis. They knew that it's going to take a while, right? You have to cut the prekallikrein out of the genetic material, right? So it's going to be a while before all that prekallikrein disappears. So they allowed people to stay on prophylaxis. And then at week 16, they had them stop the prophylaxis. And you can see pretty good data, right? You see one attack in these. Now, they do have some further data that shows it's about 83 or 81% effective. Some of it suggests even into the 70s. But the nice thing about CRISPR technology, unlike traditional viral technology, is that this is a lipid bead that Intellia uses. It doesn't use a virus. Once you have the adenovirus, you can't get it again. But a lipid bead doesn't cause any immune reaction, and you can repeat the dosage if you need to. So if you underestimate and don't inhibit the pathway enough and you still have an attack, you can go back and get a second treatment. What about deucrictibant? This is the oral medication for, this is working to inhibit the bradykinin receptor. This is the slow release. You can see here 2 different doses compared to placebo. It looks good, and it looks like it's just as good as the injectables. So about 85% with the 40 milligram dosage. So they also, like I said, this company also is looking at deucrictibant for rescue. So this is looking at their on-demand use of it, right? So you have 98% reduction, or I should say within 12 hours, 98% of people felt they were getting better. If instead you look at their severity, that is 2 clicks that show improvement of severity, 97.7 in 12 hours reached that. If we looked at complete resolution in 24 hours, it's 85.8% achieved complete resolution in 24 hours. Well, then we have sebetralstat, right? That was the new medication that was approved just a couple weeks ago, which is rescue tablet, right? So this is looking at their data. This is hours on the x-axis, y-axis is the percentage of attacks. So you can see the placebo people. You can see the actively treated at 6 and 300. The dose that they're going to market with will be the 600. They'll take 300 tablets. I do want to point out something, though. Remember, I said there were 2 new publications by colleagues of mine that are really great researchers and so on, that looked at doctors around the world. The other one looked at doctors and patients from around the United States and their diagnosis of type 3 or normal C1 inhibitor. And from their data, it looked like there's thousands of these people out there. And we always looked at it extremely rare, just a fragment, like small fragment of everybody who had HAE. And both these papers kind of suggest that that's not the case. But one of the factors they used is response to these medications, right? So let's just look here. So let's look at 2 hours. So this is really looking at placebo compared to active. But if you looked at people who had histamine-induced disease, right, who wouldn't respond to these medications, right? So that's what they're trying to say. If you respond, you can tell that you have bradykinin-induced disease. But let's look at 2 hours. So these all have bradykinin-induced disease, but at 2 hours, not everybody was better on the active drug, and there was a lot of people who weren't, who were getting better, who were not on any drug, right? They were on placebo. At 4 hours, a good 40% of those people who are on placebo are getting better. And histamine disease is supposed to resolve quicker, right, by itself. And if you look at people who were actively treated, not all of them were treated. So I would say to look at patients, you give them icatibant and you see if they get better in 4 hours. And if they do, you say they have bradykinin disease. I don't think you can do that. And that's why I'm really leery, not only because of the treatment they received, they didn't fully exclude histamine-induced disease, but they also didn't prove to me that they had bradykinin disease by a trial of these medications. So where are we right now? So we have 4 minutes left, and so my summary is, in the past we focused on treating attacks, now we're preventing attacks. I have 75% of my patients now on prophy. Newer medications in development have an increased efficacy and less burden, and that's the benefit. But I am hoping that it's going to lead to increase in access to those people around the world. And I think right now we're approaching a relative cure. You know, grant you, I don't know who's going to pay for CRISPR technology, but if their data comes out to be safe, which it looks like it is, and it does work, wow, that'd be cool. That, you know, you could receive CRISPR technology and maybe carry your rescue medication for the rest of your life, but possibly not have an attack for the rest of your life. So with that, I'll say thank you for the opportunity to talk to you. We have a good group here, you know.